This one states, hello, I'm 41 and wasn't feeling as energetic a few years ago, so my doctor started me on HCG, human chorionic gonadotropin. The testosterone went up and I felt better for a while, but then it started to dwindle. A test back in February showed my testosterone levels back at the same numbers as before. The doctor then talked about exogenous testosterone and the delivery systems. He said that the cream is natural and has the least amount of side effects, and he puts in parentheses, acne and aggression. I tried one pump for a month. Prescription was for Versa-based 1 to 2 pumps, but I wanted to try the lower one first. Putting it on my inner thigh, I did this along with HCG. After a month, my testosterone levels were the same, and my doctor said that I might not be rubbing it in enough and to also go to 2 pumps on the back of each knee. I've been doing that for almost a month and rubbing it in much more. I'm going to get my blood work done again next week to see if the 2 pumps has been helping. I don't feel much different yet. My main question is, do you think the cream is as effective? I was thinking about moving over to sub-Q injections. Any insight is appreciated. Thanks for all you do. Okay, where to start? So at age 41, the likelihood that HCG is going to work is pretty slim. I have seen testosterone levels, total testosterone and free testosterone, rise as a result of the stimulation from HCG. HCG is a homologue of luteinizing hormone, which is what the pituitary produces to send a signal to the testicles, the Leydig cells specifically, to produce more testosterone. But at 41, even if the numbers come up significantly, the patient, in my experience, says, okay, great, I see the numbers. I don't feel any different though. I don't feel good. So somewhere around, again, this isn't my experience, around 30 is when we start talking about, you got a 50-50 shot here, no pun intended, as whether or not you're going to feel any different. And there are all kinds of factors that you want to include in there. Are you going to get, are you looking to father a child soon? There's emotional attachments to not being on synthetic testosterone, even though you're on something else this is certainly, none of this is natural, but there's all kinds of things that come into play here. But what I don't have here to enable me to answer the question is I don't have milligrams. I don't have the dosage. What is 1 click? What is 2 clicks or whatever it is? It's just clicks or pumps. I don't know what that equates to.
Oh, yeah.
And a lot of physicians, particularly those that don't have experience in this area, makes sense, right, will tend to underdose, particularly with the creams and the other topical formulations, because there you're going to see more of a day-to-day increase and decrease, right? Much more of a fluctuation. That's why you have to put it on every day. And actually, contrary to what he says here, I see more side effects with that because of that big swing than I do with something that has a more steady dose. The sub-Q injections would be a pretty steady titer typically because you're doing it every day, which goes back to another thing, kind of defeats the purpose, right? Of something that's esterified. But if I can keep from going off on tangents here, the creams typically are not as effective in terms of satisfying why the patient came in to begin with. Decreased libido, decreased sense of well-being, decreased energy, decreased ability to change the body composition, increase muscle, decrease fat. So I'm not a big fan of creams. They're also something you have to apply every day, wait 5 minutes to dry, another 25 minutes to be fully absorbed before you can do anything with it. You run the risk of contamination, meaning, if you've got a child that likes to sit in your lap and you just put it on your thigh and you're wearing shorts, there's issues that come with it. Not that you can't get around those issues, but the other thing too is, in regard to the side effects, what I've seen with these is you're going to see much more many more metabolites of testosterone. So you'll see, for example, higher titers of dihydrotestosterone from daily dosing, because the body doesn't like those big swings, so it tends to overreact, if you will. Again, that's just been my experience. But I don't know what the dose is, again, I'm stating, so I don't know if you've even experienced therapy yet, because the thing about testosterone is and we've known this since the 1950s. I swear I've said this before. Back then they used total serum testosterone. 800 nanograms per deciliter was sort of the cutoff, below which the patient didn't get any better with clinical symptoms. Above which patients said, "Hey, this is working." So you spend a lot of your time outside of that range. Now, you don't treat numbers, you treat people. But that's part of the problem, is that this delivery system is just going right through the skin, and then your body's metabolizing it right then and there, and you might be lower the next day than when you walked in the first day at the office, once you've been applying this for a while. Now, again, the object is to get to the cheese, and if you feel better, great. But a lot of times, you have so many issues with this. If you're not a good transdermal absorber, you can't get enough in, and people have to dose twice a day and dose twice as much. But again, you deal with this widely swinging titer, and guys are up and down. Now, if someone comes in with very low testosterone to begin with, they think that these creams are the best thing since sliced bread, because feeling better for 2 or 3 hours is better than not feeling any better, right?
Yeah.
But invariably, once they go from a cream to an injectable, something that's esterified and therefore time released and keeps a steady titer up above that, it's different for everybody, but the average is roughly 800 nanograms per deciliter, then they feel better. If they don't hit that, they don't feel any different. And testosterone's interesting in that regard, because it's that therapeutic threshold that's a minimum under which you won't feel any better, but over which it really doesn't matter where you go. I mean, it does, because as I said earlier, the body doesn't like the big swings. So if you go really high, much higher outside of homeostatic range, the body's going to try and convert more testosterone to other metabolites, estrogen, dihydrotestosterone, etc. But with TRT doses, okay, you're not going to hit any ridiculous numbers, but it's still outside of the normal limits. So doctors are hesitant to give a therapeutic dose.
Yeah.
I hope I circled back and made the point there that I was trying to make from the beginning, is that we don't know. So let's get down to brass tacks. 200 milligrams per ml is a typical starting dose with a delivery system that gets it through the skin pretty well. 200 milligrams per ml of an esterified form of testosterone injectable per week, okay, is also the number that's a typical starting dose for guys that are in the business for a long time. Urologists, I think Baylor's is probably the best in, don't send me letters, but I'm partial to Dr. Lipschultz and his group of fellows, but I think they've established this for a long time, through a lot of studies that go back 50 years even. So to get back to the questions here, instead of my riffing, I don't think the cream is as effective. I'm not a big fan of subcutaneous injections because on the one hand, you can inject yourself every day or every other day, and that kind of, like I said, defeats the purpose of having an esterified form of testosterone. If you want to do it once a week, it's very difficult to avoid having what I would call a big bleb, a big spot where you've got this oil base that's not being absorbed. You're putting it in fat. There's not much vascularity to fat, so it takes a while to absorb it, which is a boon in some respects, but then you got this thing that can become infected and just become a source of aggravation, we'll call it. So you got to weigh those two. Am I missing anything else? I would make sure that you follow up with testing to see what your assays are, so you can see if you're not getting results, if it's because you're underdosed. Again, I can't tell by pumps. HCG is not going to do it at 41 years old typically. Now HCG can still be used because we have receptors for LHCG. Again, they're homologs, so they're so close to one another in structure that they combine them in labeling them. But you have some of these receptors in the brain, and when you go on TRT, you're not going to be producing LH anymore, or certainly very little. So there's a case that can be made to go ahead and supplement with HCG just for that reason. But for cosmetic reasons, so you avoid testicular atrophy, for fertility reasons, to preserve fertility or TEMP2, you could use HCG. But for testosterone replacement therapy, I think somewhere around 30 years old, you got to weigh pros and cons and decide if you're, want to take a chance to see if it works or not, because it typically doesn't.
Thanks, Doc.
Sure.
What else we got?
Hello, Doc and Jay. Jay.
I don't know why you said that. It's just channel.
You mean Big Dave?
JTV.
I'm a 24-year-old male, healthy and in good shape, and I'm an ex-Division I athlete, and I'm now in my first year of medical school. Congratulations. Previously, I've used Ostarine for 2 months and experienced nice gains without any known side effects. All right, well, I stand corrected again. I did not have any labs done. This was about 2 years ago. So you don't know if you had side effects with your lipid profile. I bet you did. I have heard you say that you do not recommend SARMs because of the effect it has on HDL. We were just talking about this.
Yeah.
For someone my age, what would you recommend as a performance enhancer if you do not believe that Ostarine/SARMs are worth the risk? At my age and being healthy, should I stray away from all performance enhancers? Was this a loaded question? I do not want to jeopardize fertility, prostate issues further down the line. Okay.
How old is he? Does he say?
24.
Okay.
24-year-old male.
That's young.
So I go back to hopefully what I finished, but maybe didn't, with the earlier question. By 26, I think then you can feel certainly safer about using this without worrying about disrupting the formation of the HPA axis. But at 24, it's better than 20, but I think you still might be in that risk. Is it a high risk? Not necessarily, not in my experience, but still, I got to be honest with you that it wouldn't be something where I could say, because you can't say much of anything in medicine with 100% certainty, but I say, hey, you're still taking a chance. Again, I plead ignorance with SARMs because there's so many out there now that I don't have experience with, and there aren't studies to support their use, what they're doing, their side effects. But I believe that, as with anabolic steroids, SARMs are going to come with the same issues, meaning you're going to lower HDL and raise LDL. And as I said earlier, is that necessarily a problem? Especially long-term, no. But I would make sure you don't have coronary artery disease, and at 24, that's probably not going to be the case. But again, you don't want to be the one in a million, so make sure.
Can I ask you a question, though? When you say you can disrupt the axis before 26, if you did do that, what could happen?
Well, then you're permanently on replacement therapy because the axis doesn't form, it doesn't operate properly, and you typically have lower levels of testosterone for the rest of your life.
I see. I've heard people like that.
The formation of this intercommunication between the hypothalamus, pituitary, the adrenals doesn't work anymore. It hasn't been fully formed. I've seen it restored. I've seen it where you go, okay, yeah, you started when you were 18, and they come in at 20, and with HCG and some other things, sometimes clomiphene, now in clomiphene, off-label use is used, but we can, because they're still 20 and there's still, presumably 6 more years worth of development, we can reset, the boards that have been crashed by this introduction of a SARM or sometimes an anabolic steroid or whatever. So it can come back. But again, if you don't want to take a chance,
I got you.
I'm not telling you what to do. I'm just saying, I'm giving you the sort of the rules of the game from what I've seen. So at your age, would I do it? As a doctor, I would have to say, for the reasons I just stated, it would not be wise.
Yeah.
And I certainly would not be the one to prescribe something like that because I am a doctor. As a registered libertarian, again, I'm not telling you what to do, but just know what the risks you're taking.
Right.
Let's see. At my age, fertility and prostate issues. Absolutely, that's one of the things that you're risking affecting. And again, it would be a long shot to permanently jeopardize fertility. Excuse me. In my experience, I have never, and it's rare that you can say that, but as long as I've been practicing, I've never seen fertility that was lost not be able to be restored if someone took an anabolic steroid or a testosterone replacement for physiological reasons. I've seen it, though, for psychological reasons. What do I mean by that? I've seen people that said, okay, well, I've got a fertility test, a semen analysis that shows I'm not producing any sperm, or I'm not producing enough that are motile or have the right morphology, etc. No viable sperm. and they're told to come off of testosterone, which is one way of doing it. Okay, your body should restore itself to its natural state, whatever that might be. But they can't do it because after 3 months of being miserable and it hasn't reset enough yet, they go, okay, forget about it, I'm not doing it anymore. So for that reason, I've seen it, rarely even, but it is, it doesn't prove or disprove anything, I guess. But for those that said, hey, I want to do this, either by using HCG in a relatively high dose, and again, I learned this from Dr. Lipschultz, 3,000 IU every other day, okay, until fertility restored. You can stay on TRT and still get your fertility back.
Gotcha.
You can also pull off the T, like I said, and speed the results up or amplify them both using HCG with no T. So it's not like in that regard you're jeopardizing fertility. Again, I can't say with absolute certainty, except I can just tell you what's happened in my practice, knock on wood, because there's probably a 1 in whatever chance that it can happen. Prostate issues, though, again, at 24, you're probably not going to see any issues with this in a large prostate because of super amounts of conversion to DHT or anything like that. So the issue, though, we do have to consider for the prostate, we know that all males have the gene for prostate cancer, and it looks like it's activated that gene or those genes, plural, by certain estrogens, particularly in the estrone family. There's actually a 2,16 alpha hydroxyestrone test that used to be used mainly for women, but could be used for guys too, that shows that balance. I just get an estrone, a sensitive estrone, so an LCMS, so we can see precisely enough to be accurate what the estrone levels are. Because in a general sense, we can tell, okay, that amount of that particular estrogen is going up too high, and that group contains the ones that are considered bad. So for that reason, I know that's somewhat Byzantine and not directly anyway because of HCG or SARMs or, and I say that SARMs, most of them don't convert to estrogen, the ones I've read about, right? Okay. So that's a good benefit. But we just don't know enough, and we still don't know enough about anabolic steroids like Anadrol that's been around forever. It doesn't convert to estrogen, but boy, it sure has some estrogenic side effects, right? So again, you're rolling the dice, and I'll leave that alone for now. But I don't think that you're necessarily directly creating a prostate issue from what little we know. But it's possible unless you control some of these potential estrogenic effects. And remember, especially at age 24, until the SARM use shuts down your own production, you're going to have, depending upon the affinity for the androgenic receptor, you may displace testosterone or at least beat it to the receptor, so you'll have a lot more testosterone floating around that can convert to these estrogens. I know, again, this sounds like pretty Byzantine, but I've seen it happen, at least as judged by the assays and seeing the elevation in estrogen, because presumably, the testosterone's floating around with nothing to do until, again, the body realizes, oh, well, we don't need to produce this much anymore. Does that make sense?
Yeah.
Okay.
Cool. Thanks, Doc. All right, Doc.
Okay, so I looked at this question briefly, and it was too long for me to read through, so I'm going to try it once again. But I have to say up front that based upon what little I picked up, I got to remind everybody that I can't be giving medical advice here. I'm just really interested in providing information here, but not medical advice per se. This is such a long, and you'll all see, question, statement, whatever you want to call it, case history. I definitely don't want to be involved or even accused of trying to present
dispensing medical advice over the internet.
Yeah, exactly, because this is not the way to do it. It's wholly inadequate. But I can give some general comments and information. Okay, so it says, "Hey, Dr. Rand and Dave, many thanks for answering my previous question on the show."
You wanted some follow-up questions before, so there you go.
Testosterone and cardiomyopathy. There's another issue that really bugs me, and I hope Dr. Rand can help. When I went on TRT about 3 years ago, 250 milligrams of testosterone and enthate intramuscularly per week, felt just great, energetic, full of life. I've also been on dutasteride for male pattern baldness, 0.5 milligrams a day for also a couple of years, never noticed any side effects here. About 6 months After about 6 months on the TRT, I decided to add a small dose of anastrozole, 0.25 milligrams every other day, just as a preventive measure. Okay, that I don't follow, but okay, I'll keep going. I never experienced any symptoms of high estradiol. I just felt great. At the same time, I decided to lower my dose of dutasteride to 0.5 milligrams every 3 days, just to see if a little bit more of DHT would make me feel even better. By the way, here in Germany, we live in the deepest, darkest medieval when it comes to TRT. It's hard enough to get prescribed just the T, especially in an appropriate dose, let alone the anastrozole. Sorry to hear that. But since then, everything slowly went downhill. I noticed a bit of anxiety creeping up in me every now and then, and my sense of well-being slowly faded away. It happened within a couple of months and only got worse to the day. Now experience night sweats, low mood, anxiety, fatigue, moodiness, irascibility almost every day. I experimented a lot with my dose of testosterone and anastrozole and dutasteride, but nothing seems to help. SSRIs, selective serotonin reuptake inhibitors, SSNRIs, another form that blocks norepinephrine uptake, what are considered generally as antidepressants, only help with the anxiety, but not the low mood fatigue. Tried high-dose sertraline and venlafaxine. One's an SSRI, one's an SSNRI. Currently, I'm on 150 milligrams of sertraline daily. For the last couple of months, I injected 125 milligrams of testosterone and anthate twice weekly, subcutaneously, and took 0.25 milligrams of anastrozole the day after the injection. See how we're going through quite the case history here?
Mm-hmm.
Even on that low dose, my E2 recently tested below 5 picograms per milliliter and later below 20 picograms per milliliter. I know that the ECLIA usually overestimates the E2 levels, so I think it would test even lower with the E2 sensitive assay. Sadly, we have no access to anything else than ECLIA in Germany/Europe to test the E2 levels. Long story short, could it be that I'm hyper-responding to even a small dose of anastrozole and or never had high estradiol to begin with, and therefore now really oversuppress my E2 over time, causing all the mentioned symptoms? Best regards, Andy. Boy, it'd be really funny if I just give you one answer, a one-word answer. Yes. Yes, actually. You are correct in that an estradiol, the standard test, is pretty worthless for guys, because I think I've said this before too. It's not precise enough to be accurate for a male because we have such low levels that we want to maintain. So I've seen on the same blood draw for whatever mistake was made more than several times an E2 serum and an E2 sensitive, and one said 16, the other said 164. That's how far off they can be. Okay, and it's not just typically an underestimate, it can be an overestimate. So contrary to what maybe you've experienced, Andy, I've seen it on both sides. So that's an issue. But if we can only judge by the clinical signs and symptoms, then yes. What you're talking about here sounds like an oversuppression of estrogen. Typically, too much estrogen can lead to moodiness and irascibility, but I have seen it where not enough estrogen causes everything from joint pain, palpitations, night sweats, typical signs of lack of estrogen, decreased mood, some anxiety that comes with the palpitations, fatigue. So, based upon what I'm hearing, I think the first thing I would do is pull back on the anastrozole, which if I'm scrolling through this, if I'm correct, it sounds like you were not using anything but dutasteride for a while. Now, if you back off on the dutasteride, which by the way has a 5-week half-life, so be careful what you're assuming here when you're making these changes, because that means it takes a long time for it to get out of your system, the dutasteride. And once you start backing off on the conversion from or from blocking the conversion from testosterone to dihydrotestosterone, you're going to have less ability, if you will. You'll typically see less conversion from testosterone into estrogen because you've turned the tides a little bit this way, right? You're allowing more of the testosterone to flow to dihydrotestosterone. Does that make sense? So that could be part of the reason why all of a sudden you were doing fine, and now because you have less estrogen being produced, you're not doing as fine. And then of course adding, albeit a small amount, everyone's different. I do have a rare few, but it's a goodly number of gentlemen that don't need any anastrozole. It's rare, but in tens of thousands of patients, it shows up plenty of times. So I don't think it's so much directly because of the dutasteride adjustments. I think it's more of the adjustment, with the anastrozole. So as I said earlier, the one word answer is yes. I think it could definitely be because of the estrogen that you're having these problems. I'm sorry that you jumped on, and I don't know how old you are, but just very, very briefly with the SSRIs, there's a lot of different reasons why you can use an SSRI or NRI that are wonderful. Chronic fatigue, there's reasons for it, but if it's just for low mood, by the very definition of the DSM-5, the Bible for psychiatry, if it's in your genes, it's going to show up in your late teens, early 20s. Now, assuming that you're in the system and can be diagnosed properly, that means if you're not diagnosed with that by then, it's not in you. Unless you get in a car accident and it changes your brain chemistry up here because of an accident or some sort of trauma, that's different, physical trauma. But a lot of times people will be placed on these for anxiety and mood disorders because their T levels are off or their hormones in general are off. So it's kind of stirring the pot up a little bit here with an extra variable that if it's possible, I would suggest that, again, in conjunction with a physician, you go over some of this and say, okay, do we tease this out, slowly and see what's going on here? Because it does make it a little bit more complicated to figure out what's going on here. But I really think that the first thing I would pursue with your physician is maybe backing off on the quarter milligram of anastrozole and use assays, because I don't see any reference to assays here, except for the E2, which again in this case is not valuable to us. And I realize the difficulty with getting an E2 sensitive, so you're kind of stuck with clinical for the E2, but you can also use other markers to see what's going on, including dihydrotestosterone and some other cholesterol-based hormones. God, I don't know. I want to give you, you spent a lot of time writing a question. I want to give you as much as I can. The only other thing I'll say here is I'm not a big fan of subcutaneous injections. There are plenty of guys who swear by it, okay? I get it. It does work for some, but I've also seen it be a disaster. I'm thinking of a pretty famous trainer, good friend now in Texas, who switched over to this and the wheels fell off the wagon. Libido fell apart, energy fell apart, body composition fell apart.
Wow.
And we couldn't figure out what it was. Actually, he did it without telling me about it and then came in to try and fix it. And sure enough, it was kind of easy to go, well, when did this happen? Let's go back to before you made these changes and let's see if it restores it. And he just went back to an IM once a week and bingo, everything resolved. So some people can deal with the subcutaneous, some people not so much. And I have no studies to support it, but there may be something to having a weekly spike in the amounts, the titer of testosterone and maybe some of the metabolites to, as opposed to having a nice, relatively steady titer. I don't know. So that's the best I can tell you at this point. But definitely, I would get involved as best you can with a physician, I presume in Germany, and maybe tease out the SSRI if you can, and see if you can raise your estrogen levels. Be on the lookout, however, for signs of estrogen excess, which would include water retention, fat retention, moodiness and irascibility, which is already there, but it's really kind of a different kind. and of course, nipple sensitivity, gynecomastia developing.
Thanks, Doc.
Thank you.